Hello and welcome to the National Data Quality Forum's webinar series. My name is Rajiv Acharya. I work for the Population Council. Our today's topic is on the Uttar Pradesh Health Management Information System and Integrated Data System to enhance use of data for decision making. The webinar will be moderated by Dr. Vikas Jadhav. My job is to introduce him and then leave the webinar to him to moderate. He works as a senior program officer and the lead for BMJF's health system strengthening work in Uttar Pradesh for improving RM and CHN outcomes. Vikas has more than 15 years of experience in public health program design, implementation in India, with a specific focus on maternal and newborn health. In the past, he has worked for many organizations such as JPIGO, Harvard School of Public Health, on MNH quality of care initiatives such as Better Birth Trial. Then Government of India's Dakshata program he has worked on. He has worked on Fox's Mannata program. He had also worked for WHO for the polio eradication program. Vikas is a physician and postgraduate training in public health. He holds a master's degree for public health degree from Harvard University, University School of Public Health, and an MD in social and preventive medicine from SMS Medical College. He is a recipient of J.N. Tata Award for the Higher Education of Indians in 2010 and Carson Family Scholarship in Harvard in 2011. Before I hand it over to Vikas, I just wanted to give you some housekeeping instructions. Everyone will be on mute during the webinar. You can ask question anytime during the webinar through the chat or question facility. After all the presentations are over, if you would like to ask the question directly from any of the presenters or the discussant, you may kindly raise your hand with the raise hand button and you will be unmuted by the administrator. With that, I over to you, Vikas. It is all yours.
Thank you so much, Rajiv. And just one more additional sort of point around housekeeping. I mean, usually we've had extensions to the webinar. Today we'll limit the duration of this webinar to 1 hour. So we'll try to get as many questions and discussion points as feasible in today's discussion, but we'll have to close within the 1 hour duration. We'll give you the opportunity to ask questions using email also if we run out of time in today's conversation. With that, I'll quickly introduce today's panelists. We have a great panel of participants. First speaker in today's discussion is Huzaifa Bilal, who's the Senior Specialist Monitoring Evaluation at UP Technical Support Unit, leading a team to strengthen and enhance use of government health data systems at various levels. And he has extensive experience in, providing technical assistance for
I think we have a little bit of problem with Vikas's screen. So he is just now logged off. I'm sure he will log in. Uh, uh, so let me try to
Applications.
okay,
Um,
because we
yeah,
lost
yeah.
you in between, so please, yeah.
Uh, Sorry, I might have a poor network. I'll have to shift. Um, so, so Mr. Jan leads the team that have successfully rolled out the facility-based HMIS, UPHMIS, MCTS, RCH portals, dashboard for decision making all across the Uttar Pradesh, strengthening the M&E framework in the health sector. His key areas of expertise are health system strengthening, public health policy, program planning, implementation, monitoring, and evaluation, for RM and CHN, health technology, MIS, advocacy, and partnership. So that's a quick introduction of our
Because it's like an
panel.
interview, because
Yes,
nobody could hear what you said about Ravi. Please say 2 lines about him.
I'm really sorry, and thanks for giving this feedback. Um, yeah, so just a moment. So Dr. Ravi Prakash is the Senior Deputy Director of Monitoring, Evaluation and Operations Research at UP Technical Support Unit. He provides strategic leadership on designing and delivering community and facility-based sample surveys as a support to health programs of Government of Uttar Pradesh. He has been playing a key role in establishing mechanisms to improve quality of existing government data systems and supporting the inclusion of survey results in government decision-making process. He's a quantitative researcher with more than a decade of experience in planning, designing, managing, and monitoring of large studies and setting up of M&E systems for large-scale interventions. He has MPhil and PhD in population studies from Indian Institute of Population Sciences, Mumbai. Um, uh, so with that, I'll get us started for today's discussion. And today's discussion is about UPHMIS. And before before the start of this meeting, I was looking for my looking for the customary. Um, uh, am I still audible? My Let me
Yes,
just
you are
stop
audible.
my videos.
Yeah,
Okay, let me just stop my video because I have a bandwidth issue probably. Uh,
sure.
okay. Uh, so I was looking for customary sort of smart quotes for data systems, to kickstart this conversation. But I found some important ones, but very interesting or funny quote also. Basically, I've been a researcher all my life, and we've heard this sort of mention that what gets measured gets improved, and that certainly holds true for our programs. And a lot over the years has been invested in terms of improving systems for measuring performance of the programs. But for data systems, I'll also add that from data systems perspective, what actually gets used also gets improved. So that's an important sort of point to remember as we talk about health management information system in today's context. And the funny quote was, data is like water, and neglect its quality and fear the indigestion. So really, really important to keep in mind sort of quality of the available information and maintaining the quality of the system. Coming to health management information systems, we've all heard debates for years on quality and whether it brings sort of adequate quality for decision making, etc. Um, but more than the quality of information, for now, the question is, how often it is used, and how sort of well it is used for actually decision making on making program priorities. And sort of this sort of inadequate utilization and potential perception of poor quality actually runs into a vicious cycle, uh, uh, which could further sort of reduce the use of data systems. And this is something which government of Uttar Pradesh actually tried to work on over the years, to not just get to a system which has potentially adequate quality, but at the same time enabling mechanisms to ensure that the information available within the HMIS is actually adequately used and used for decision making, so that the feedback loops are positive in nature and quality of the product actually continues to improve. UP HMIS is a massive system which runs today more than 28K transactions in a month, more than 1,000 users, and more than 1.7 million sort of data updates, and there are sort of the frequency of data update is monthly. So that's the system which we are going to talk about today, and we'll start with a presentation from both our speakers, and then we'll hear from our discussant for today. So I'll request speakers to actually kickstart and conclude their presentation in 20 minutes or so, and then we'll have some sort of questions for our discussant, and then we'll open up for questions from participants. And along the way, people, if you feel there are burning questions, continue putting them on chat and we'll pick them up later. So over to you, Ravi and Huzaifa.
Thank you so much, Dr. Vikas. So my screen is visible? Yes.
Yes.
Okay.
Yes.
Okay. So thank you so much for setting up the context, and I would also like to thank NDQF also, as it's providing a platform to share the learning and learn a lot that what is happening in different geography. So thank you so much in that. So I will take the first part. So before diving into the today's topic, what Dr. Vikas has said the context about the UP HMIS and how about the complete data for decision making process. So I would like to quickly brief about the UP and what UP TSU is. So as we all must be knowing that UP is having the one of the largest populated state of the country and contributing around 235 million population. So in terms of the scale, if we will see, the UP can produce a country like Australia, Canada, Germany, United Kingdom in together. And one of the lowest health outcome, as we all know, that UP is actually contributing most in the global and the national deaths and the disease burden. So this is such a kind of state that we all are working here. And about the UPTSU, so UPTSU came into the UP in 2014 and is basically the Bill and Melinda Gates funded program, and which primarily led by the University of Manitoba and India Health Action Trust. There are some other partners like John Hopkins University, Jepaigo, Clinton Health Access, and there are some medical colleges which are working in the UP as the key partners in the UPTSU. And UPTSU is working across all the domains of the RMNCH, which includes the MNH, family planning, nutrition, and the immunization. And across those domains, there is a health system strengthening intervention, which UPTSU is providing a support to government of UP, in which primarily includes the human resource strengthening, supply chains strengthening, and one of the which we are going to talk about, the data system strengthening component. So this is about the brief about the UPTSU, and the principle of the UPTSU is like, so we believe in the improving the availability, quality, and utilization thing, and it across the continuum of care of postnatal care, early childhood, adolescence, pregnancy, so which covers all the domains. And we believe in the embedded approach, like, so we don't have any our own goals. So whatever government want to achieve in the system, we just provide the technical assistant into that. And we try to work to improve the equity and the equality in the health services. That is the program science approach, that is the philosophy of the UPTSU, that on which we are trying to work here. So today's topic about the UP HMIS. So UPTSU, when established in 2014, so data system strengthening was one of the key domain of the UPTSU, and in which the goal was to improve the use of data for decision making, that how to improve the evidence for decision making processes. So initially what we did is we tried to identify the gap, actually where the gap is, how the system actually exists in the state of the Uttar Pradesh. And we tried two gaps in the three different category of the gaps in the data availability, the data quality, and the data use. We saw that these three are the major buckets where the gaps we actually found. So in terms of the data availability, what we see that there is a lot of paper-based reporting system was there. We called it as the MPR. So every month there are a lot of 30-40 reports which district is used to report to the division and the state. So this is the huge reports was existing in the system, and it's all the paper-based reporting system. Second thing what we saw in the data availability thing is that there are the many of the critical data elements that which program managers actually use to take the decision was actually not available in the system, due to which many of the time review was not able to happen on those things on which the decision need to be taken. Many of the facilities what we have seen was what are not actually mapped in the system, due to which we are not able to get all the data, and the timely data availability was definitely was one of the challenge in data quality. So the data quality, so platform was completely missing. There was no accountability in the that who will do the data quality analysis, what how to improve it, who will be accountable for the data quality. Such kind of system what we found was actually missing on that time during 2014. In the data use thing, what we see that the uniform framework was actually the lacuna in the system. So some of the district was actually kind of reviewing on the financial component, some of the district was actually kind of looking into the JSY thing, some based on the state priority, and some campaign kind of thing. Similarly, the complexity of the data. So if anybody wants to analyze the data up to the facility level, that was kind of one of the major difficulties. So even the downloading the data and getting analyze the data up to the facility level, one of the challenges. And lack of resources, definitely, as in other program we always see there is a lack of trained human resource was actually one of the challenge, that who to analyze it and to give the feedback to the system. So these are some of the gaps what we have found in the system, and based on which we try to develop some packages and approaches that how actually we should be able to improve the data quality and data use system in the state of the Uttar Pradesh. In view of that, what we always keep the core principle is in our head and in our all the approaches is that we are not just working on the improvement of the data quality and the data use. The way we are working is we always see data use as a intervention that could ideally at the end should affect the health outcome. So if we would be able to have the effective review, effective planning based on the data, so there would be a change in the health outcome as well. So these kind of things we always plan, and we whenever we plan our intervention we always kept those things in mind. And based on the gaps what we have identified, we created a bucket of the package of the intervention which complement the GeoUP data system, which support in the data quality, which provide the tool for the data use, and the system we should be able to build the capacity of the government system so that the system should remain sustained. So based on which there will be the increase in the data availability, data quality, data review, and the better capacity. So we will be able to achieve the effective database review, planning, and decision making. So for complementing the GeoUP data system, so initially there was the HMIS, and the strengthening of HMIS was remain one of the core area, and the UP HMIS came into the picture, which complements the HMIS actually. And the establishment of the beneficiary level data system was one of the key that on which we are discussing in today's period. For the data quality thing, so time to time there's a different interventions came into the picture. So like data quality audit, validation committee meeting, data entry at source. Similarly, for the tool and the review mechanism, the dashboard came, and how to make the uniform process for the review meeting. So these kind of interventions and the guidelines we come up. And for the capacity building, there is a different training packages, and the establishment of the dedicated divisional M&E hub was remain the key intervention, that with the help of which we would be able to improve the data quality and data use in the state. So this is something what we have learned, that just by having the one UPHMIS system would not be able to improve the data quality and data use. We need to have a package of the intervention which should act at every place, then we would be able to actually improve the data quality and the data use. This is something what we have learned during the course of the time. So initially, when we started working, only HMIS was there, and I've already discussed about the what are the key gaps. So under the leadership of, we are fortunate that Mr. BK Jain is here. So many of the guidelines was released. So that policy was actually missing in the during the initial period of the time. And at least in for the HMIS, we would be able to have some of the government order and the guidelines like timeliness, periodicity, private facility reporting, availability of the HMIS format, accountability for the data. So these are some of the guidelines that which are the base for reporting of any data were actually missing initially. And then we had a different rounds of meeting, and we would be able to set the government order and policy for these decisions. In the meantime, that what we've also observed that I've just discussed, there is a different manual paper-based reporting system exists in the state, and there is a duplication of reporting as well. So the state also worked towards it and decided that we need to have a paperless reporting system. That was the decision of the cabinet that time, that we should move in all the domains. So health is also one of the division, one of the department which decided that we need to go to the paperless system. At the same time, so in the 2015 there was a one government order that which stated that we need to use the HMIS data for the decision making. But when we started working on it, we realized that the program managers are actually not able to take the decisions just based on the basis of the service delivery data. So for example, in the district, what we have seen is the CMO and DM used to say just improve the institutional delivery. But how to improve it? What are the factors which are actually affecting the institutional delivery? Whether it is the HR, whether it is a drug, whether it is the equipment, or it is the infrastructure. So such kind of data was actually we are not able to have in a system, and we need to have a data on which program manager would be able to take a decision. Second thing, there is a lot of paper-based reporting and the complexity of the data set, which actually make that difficult for the program managers or even for the program analyst or the data operator people kind of thing that to analyze those kind of information. And there are a lot of duplicacy. So we mapped the 80 formats and we found there is a 48 formats is actually a kind of duplicates. Second thing, state always had a different kind of priority at the different time of period of time. So the customization in the centrally owned MIS is actually is very difficult. So state need to have the self-owned state-owned system on which state need to have their own priority, own customization, and should be governed by the state. So this leads the whole conceptualization of the UPHMIs that we need to have the one integrated system where every other portals can be integrated and we can have the access and we can develop the dashboard and everything based on this system. So this is the complete rationalization behind the UPHMIS came into the picture. So as many of you must be know that UPHMIS is the DHIS2 based platform and governed at the by the University of the Oslo, and it's an integrated portal. And to UPHMIS can also host the comprehensive data for the dashboard display. And initially there was a 4-step process that we mapped all the existing formats and release of government order, and then we had a UPHMIS campaign due to which we, in a very limited period of time, would be able to establish the UPHMIS in the state. So as I said, we need to have the different quality strengthening approaches as well, and which includes the data quality audit. So data quality audit is the supportive supervision approach for assessment of data quality, and for which state has actually constituted a 7 team as well, which comprises the member from the medical health, TSU, NHM, and they conduct the audit, match the portal data with the source documents, and identify the quality how it is. Second, validation committee is a dedicated platform to review the data quality status, and which governs the committee member to review the status and suggest the corrective action that how to improve the data quality. Next is what I was talking about, the state should be able to do the customization. In 2019, what happened after 2-year period of the time, so state actually do the data rationalization and decided we need not to have these data elements and we need to have the other data elements. So state did the data rationalization in 2019 and significantly reduced the many of the data elements which were not suitable for this period of the time. So this is the advantage of the such kind of system. Then again, time to time we bring some of the intervention. So recently we initiated the data entry at source, which is UPHMI subcenter application. As we all know, in UP that subcenter is reporting to block directly, and which leads to a lot of time in the data transfer, and the computer operator here is have to spend lot of time, they have lot of load. So tablet is provided to the ANM, and now ANM can directly enter the UPHMIS data into the subcenter, and we have seen some good results which Dr. Ravi would talk about. So divisional M&E hub is the dedicated platform that this is something about how to build the capacity of the government and how to make the system sustainable. So divisional M&E hub is established in 18 divisions, and the role of these people that how to improve the data quality and enhance the use of decision making. So this is something towards the capacity building thing and how to make the sustainable all those things that the things which we have just discussed. Yeah, so next is the data use strengthening approach is that we come up with some of the tools like UP Health Dashboard. This is again based on the UP HMIS. UP HMIS hosts the UP Health Dashboard, UP Health Bulletin, and the Decision Tracker. So Decision Tracker is something based on which program manager can track the decision, whatever decision they have made. We establish a process in the form of guideline, like how to review the data. The first step is kind of gap identification, then action planning, then implementation, and the kind of tracking, and which is reviewed at the different platform like the state, division, and the district, and which in turns we are hoping that will show the sum of the health outcomes. So dashboard is, as I just discussed, is the 14 indicators, and 2 indicators is actually from the data quality, which is also important, that the people should not be able to manipulate the data. At the moment they will start manipulating, there will be a their effect on their ranking. So this is something review mechanism that we have been established, implemented at the state and district level. So the state level is using the dashboard, which actually UPHMIS hosts it. The first step is kind of identification of the poor performing district, because all the districts are not poor in all the indicators. So this is the first step. The state is identifying it and notifying the districts. Districts is identifying the poor performing geography, and based on which they prepare the action plan by identifying the factors which is actually affecting. So every district is, every block can have a different factor. So some block may have HR is the problem, some may have the equipment have the problem, but UPHMI is actually equipped with such kind of information and able to analyze. The program managers will be able to analyze and prepare the action plan based on these low performing geography and low performing blocks. So this is something about some of the key interventions that what we have implemented in last 3-4 years under the leadership of NHM and the directorate time to time. Now I would request Dr. Ravi to give us some insight on some of the key learnings what we get it from those interventions and some of the results. So I'm giving you the access, Dr. Ravi.
Thank
Yep.
you, Huzafa.
Thank you, Huzafa.
Ravi, can I request you to finish it by 7:05, please?
Sure,
that we can-
sure,
Thank you.
because I would be quick. And I think the important, many of the important things have been covered by Huzafa, where the rationalization of why this system was required, and then how it has been helping. So maybe I would focus just on that few learnings what we have till now, and just to begin with, Huzafa, I'm not able to run the slide.
Change it.
Yeah, can you change on my behalf? I'm not able to do that.
Yeah.
Okay, so maybe just to give you a very quick snapshot, and what Vikas also mentioned is that the volume of the data which the state is handling is quite huge. So like more than 28,000 facilities which are entering 1.7 million records per month, so which is really a massive work in itself. And anything when we talk about the expansion of, or the establishment of any system, the important is that we are getting the information uniformly across the the facility. So what we have learned that over the period of time we are getting the data from all the sources, and also when we have done the external auditing part, what we have seen is that over the period of time the data quality has been improving from say less than half, 57% to more than 70%. So this has been a kind of success, I would say, because of the fact that the implementation part has been successful over the period of time. Next. Yeah, so this is something around looking into the data completeness, and again it has been the journey for us, wherein from between April 17 to like 20 by now, we are seeing that more and more facilities, as well as at the overall level, the data completeness has been improving. And this has been not only at one level but across the facility. If we say that the CHC, PHC and subcenter, DH has been, district hospital has been a kind of issue for us as of now, but I think our concrete interventions and focus at the DH level is going to ensure that we have the more complete data at the DH level. Next, please. We also try to see that how the data quality of the over the 2 rounds have been improving, and when we looked it from the matched facilities, we are finding a very significant improvement, like for example 49% the matched elements to the 70% matched elements over the period of time. So this again shows that once you build the system and when you have the system for modifications, alterations, and customization depending on the need of the uh, of any geography, we can achieve a lot more success. This is also reflected in this graph, where we are seeing that the more and more facilities or the data elements which are being reported into HMIS as well as on UPHMIS has been consistent, and the variation has been reducing over the period of time. UPHMS also gives you an opportunity to check the data before it is getting uploaded to the server finally, and then we are doing it or measuring it through the validation errors. And over the period of time, we have seen there has been consistent decline in the validation error breaks. So that means the platform which has been set as a validation committee platform has been or were successfully able to make the data more consistent, or maybe make the data more internally coherent. We try to look into whether some of the key indicators which has been looked at the highest level, maybe I would say for the state health ranking itself, you see that over the period of time from 2017 18 to 19 20, you have been seeing that the variation has been reducing, or the gap or the variation across the facilities has been reducing. This means is that your data is coming more accurate, and you are getting the most of the facilities in the state are reporting the correct data, which was not the case earlier. The platform or the enhancement which Josefa talked about, the data collection at source. So the paper based to shifting to the digital or the digital platform has also led to the ANMs, the ground level workers, to enter and upload the data directly from their own tablet phones. And we are seeing that this pilot has started since January 20, and from January in Ayodhya, and then from August onwards across the 30 districts, we are seeing that the data is becoming more and more consistent, and the level of the validation error that has been reducing, and it has come to a negligible level. So I think these kind of interventions gave us opportunity to make it more comprehensive. The other part which Vikas talked in the beginning, that how we are making the use of this data, and we have the system of tracking the decisions in the UPHMS, where the analysis has been presented to the district and block level, and they are taking decisions which has been followed up subsequently, and in order to ensure that whether those decisions are kind of fulfilled or not. So if we track over the period of time, a lot many decisions have been taken, but we are just presenting for last financial year, where 306 decisions have been taken based on the data which either has been analyzed or presented, or has been directly taken from dashboard, and based on that decisions were made. I'm not going into detail about what were the decisions, but just to give you some sort of glimpse that we identify the problem, we identify the geography where the problem is happening. Like for example, here is the institutional delivery, and with the help of the data like input data, UPHMS data, we can clearly see that why the institutional delivery, for example, in this case is low. So do we have the enough delivery point for the which requires considering the population, or we don't have? And we clearly see that if the delivery point itself is not there, we anticipate that more and more home delivery might be coming into picture. So this UPHMS actually helped in identifying these kind of nuanced gaps within the system, not only the programmatic gaps, but also gaps in terms of the system availability, and as well as quality, which can further lead to enhancement into the outcomes. So like for example, here again, even if the existing delivery point is there, whether we have the staff nurses or not, or even if we have the staff nurses, whether they are trained or not. So I think these are important points for any decision maker to see and take a decision. And I think moving beyond the HMIS, and I would say that complementing the HMIS, this UP HMIS input data gives an additional insight for the program makers. And this is an example where the district authority has taken a decision, and then these kind of meetings are happening on a monthly basis, wherein various program components are being focused, and the data has been used for decision making. So we try to also analyze at the aggregate level 25 HPD what is happening, and we are clearly getting a sense where there is an improvement in the where the places where the action plans has been developed, they have been completed based on the decision tracker data. There has been a significant or better outcomes, program outcomes, compared to the areas where we don't see a lot more actions have been completed. And this kind of analysis is also being presented to the state to kind of reinforce that the data-based decision making are important for the program improvement, not along with the routine, the programmatic changes which are taking place on a regular basis. So I think I've done with my section, but I would just say that keeping UP as a large scale geography with so much of diversity, the system gives you a kind of confidence that maintaining or implementing these kind of designs are feasible and it can be done. And also the flexibility of making the interim changes can also not only enhance the data quality but also data use, and depending on the need, I think similar efforts can be replicated into the other setting. So I would like to thank you all, NDQF, for giving us opportunity to present this, the government of UP and NHM for their kind support and ongoing support, and of course the Bill and Melinda Gates Foundation for the financial support or the funding to run out these interventions and helping not only nationally but also globally the data quality improvement efforts. Thank you again.
Thanks, Ravi and Huzaifa, for a sort of comprehensive presentation covering almost all aspects of collection, collation, quality assurance, and utilization of data. So really fantastic job. And with this, we'll quickly go to Mr. BK Jain for his reflections. And sir, from your side, I mean, you please feel free to sort of give your broad reflections, but I'd specifically request you to speak a bit about how the UP HMIS, which in your words you've used as a complementary system to the HMIS system, how is it sort of improving your day-to-day sort of work data for decision making bit? First that, and second, a lot has been said about this being a paperless system, potentially excluding eliminating duplication of data. So what are some of the sort of interventions which you have done to ensure that it's truly a paperless system and does not include a lot of duplication of information being inputted by various health workers? Sir, over to you.
Thank you, Vikas. All I want to say, as you are aware, HMIS platform was introduced by Government of India way back in 2009. And initially, if you see, facility-wise reporting was not there. When gradually Government of India built that platform, and then facility-based reporting was introduced. So, as indicated by Huzaifa and Ravi, this exercise for identifying existing formats was carried out, and all stakeholders were invited in our office. And it was found that more than 80 formats were there at that time, which were not captured by HMIS portal. As you are aware, HMIS captures mostly information or data pertaining to the segments which are directly funded by Government of India. And there are many areas like national program, communicable disease, non-communicable disease. These programs are normally not captured in that portal. So that exercise was carried out. All stakeholders, including directorate officials, they were invited here. and we found more than 48 or 45 formats were there, which were indicating there was duplication of data, and some information was in few formats, and the same kind of information was there in some other formats. So that exercise is extensively done by us, and based on that, digitization of remaining formats which were not there in HMIS portal was done in UP HMIS. And if you see, when we talk about duplication is not there, if you see whatever is feeded in HMIS portal is carry forward in HMIS portal. So there is no effort, that effort is not repeated. So, and whatever portion or formats are not captured in HMIS are captured in UP HMIS. Then a decision was taken at the level of Principal Secretary Sir, and a GO was issued that no MPR will be taken by directorate or at the state level, and everybody has to do reporting on portal only. So that was a very good step taken by the highest authority in UP. Then, as you know, AROs are there at block level as well as at district level. They were trained repeatedly. First, orientation training was done. Then, after that, refresher programs were done, and they were trained how to capture data on the portal. Then, once again, this exercise of rationalization was done after 2 years. This exercise was done, and then we found several new programs were introduced during the 2 years period. So whatever new requirement was there and that was added, what was redundant or not applicable in 2019, that was deleted from the portal. So repeatedly, as you know, software development is a regular exercise, and whatever feedbacks are received from field or at state level officials, we are trying to modify the portal as per the requirement of state as well as the districts, and several reports are added and several reports are removed if directorate or requirement is not there by the other officials. This platform has definitely helped us in many ways, like if you see, there are many limitations. When we talk about HMIS portal, there are many limitations. If a change is required in the portal, then GOI expects the same kind of request from all states. And those requests cannot be, is whatever we want, say what is the whatever demand is from our side, it may not be a demand from MP or some other northeast state. So that kind of limitation was there. So here advantage with UP HMIS portal is there. If at any stage there is requirement of new format, say for NBSU or some other schemes, several new requirements were there, and according to our requirement, those formats were introduced in the UP HMIS portal. So reporting was started, in real-time reporting was started, and we are getting reports based on those schemes also. So this platform provides us that kind of flexibility. So this flexibility was earlier not there. Then, as you have mentioned, the quality aspect. So I think Huzefa and Ravi both have already covered this portion. So we have validation. We have formed validation committees at various levels. If you see the reporting structure, it starts from subcenter to block, block to district, district to state. So we have validation committees at the level of blocks as well as district level. The role of those validation committee is to first during a month's time, whenever data is collected, validation committee is supposed to check that data which is captured, and they check with the last month report. They check for outliers, and the validation errors are also seen by them. And then once the data is fed on the portal, then they do checklisting of data, because as you know, if the data is forwarded to a higher facility, then it cannot be corrected or deleted by the concerned facility. So they have to be doubly sure before forwarding the data. So validation committees are there at all levels. They are supposed to check the quality of data at their end. Then at the state level and at district level, there is another validation committee. Their role is again to check the data which is forwarded to them at district level. They check the district level data twice, and then again it is forwarded to state level. Then as mentioned by Huzaifa, we have a very good concept of M&E hub, and they have really acted as catalyst during the whole process. If you see now, their role is to check the quality of data at all stage. As you know, in each division we have 3 districts, 4 districts, 5 districts, depending on the size of division, and they are supposed to motivate district officials, including the district functionaries, and they ensure 100% reporting and correctness and timeliness in the data reporting. And they are really playing a very good role as far as reporting of data is concerned. And based on the data which is captured on UPHMIS portal or HMIS portal, what we are doing, we are identifying low performing geographies, and we are finding the gaps in human resource or infrastructure or logistics or service delivery, and based on that corrective measures are taken at the level of districts. And as you are aware, now the reporting, which is reports which are generated by UPHMIS portal, they are presented before the district health societies, and so that all stakeholders, including DMs, ACMOs, MOICs, everybody is there in the DHS meeting, and including other departments, so they can see what kind of gaps are there in the district reporting. They can identify the blocks which are poor performing on various indicators, and directions are issued then and there, and those directions are minuted, and district official and block officials, they are asked to take remedial or corrective measures on that. Then during the time of as you know, during pandemic time, so what is happening, we are holding Zoom meeting or virtual meetings with the district officials as well as the block level officials. Refreshers trainings are taking place using those platforms. So, and whatever their queries are there, we are trying to address them. And we have, from time to time, we have revised the instructions relating to this UPHMIS portal or HMIS portal, and then validation committees. And from time to time, we have taken all those steps.
Thank you, sir. Thank you so much for your reflections. And you know, we have a very busy question and answer sort of chat box, and you know, we are looking at it, and so from to save time, what I'll do is I'll simply not describe each question as it was posted, but sort of club these questions into categories, because many of your questions were actually focused around, you know, central themes. So first one was around data quality, you know, which was a lot of it was covered by Mr. Jain and Huzaifa and Ravi, but I'll pick up, and there were questions by Kanishk, Mr. Jalil, Ahmed, Rajib, sorry, Bidu, Anand, and others, you know, related to data quality. I'll pose two questions probably to Ravi. One is, you know, what's the definition of data quality, whatever the indicators which you mean? And second is, um, uh, how do you ensure that you know, data is not manipulated after it has been validated by these data validation committees? so that's one set of question to Ravi and maybe Huzaifa. For Mr. Jain, sort of another set of question is around the data meeting the requirement of Government of India reporting requirement, and at the same time looking at some bit of sustainability of the system, as TSU support weans off. So Mr. Jain, I'll request you to come to that question. But first, Ravi, on data quality questions quickly, and then I'll come to Mr. Jain.
Yeah, thanks, Vikas. So I think for the data quality, as you know, that it is again, as the process improves or as the system matures, you have the different indicators for the data quality. So initial indicator which are there for the data quality is that how much data is consistent with the data what you get on the paper. And one of the efforts which we had described was that data quality auditing which has been done, and till now we have the 7 rounds of data quality auditing which has been done. And over the period of time we have done 2 sets of data quality audit, one within the same facilities and one is the across different facility. So that particular part, when we compare it with the data at source and when we look into what data which is there in the system, I think that comparison we measure as a data quality, because it has to match with whatever data we have in the system. That is the one part. And second important thing is that the internal data validity, when we talked about. So for example, you have the indicator on NENC and you have the indicator on 4+ ANC. So ideally, if you are comparing that, it has to be consistent and not that one and other is going in completely different directions. So we the first level of auditing is or the data quality measurement is by looking into that what we have as a source and what we have in the system. Second level is that how they are talking about in terms of each other when we talk about different indicators. So these two measures were considered, and the value 57% was coming from the matching it from the source data. So in the facilities which were covered in the first round of data quality audit, the 57% of the domains among the domains where the data quality assessment was done, 57% of the data was matching from the source document, which has increased to say 75% over the period of time. Yeah. And the second, if you want me to answer on the data not getting manipulated, so I think one of the important thing, if you see, I would not say the limitation of the HMIS, but I would say that there's a provisioning in HMIS that you can correct the data, or you can modify the data for the whole financial year, at any given time of even at any given point in time. So for example, when we were analyzing, to just give you a very quick example on the institutional delivery, what we found is that the data which was there in the month of say March, when we had downloaded earlier, and the data which got freezed, lot many information which were coming from the private facility, and which suddenly jumped the levels of institutional delivery. So whereas in UPHMIS, what has been done, and again has been discussed with the government, with the earlier managing directors. So we have fixed a limit of 3 months. So for example, if you are having any sort of data changes happening, it can happen for a very correct reason. For example, if some of the facilities could not enter the data due to some unavoidable circumstances and so on and so forth, so they have the opportunity to complete their data, to upload that data. So we give a 3 months period wherein we allow them to enter the data or change the data, but after 3 months it is freezed, so you are not allowed to do any changes. So the data fabrication or modification is very much limited in this system, and thereby you are seeing that lot many information is coming in a very consistent manner in through this system. Yeah, I would stop here.
Jain, to you now. Questions on, and I'll add one more question which is very relevant on, you mentioned about divisional M&E hubs, and there is this question about whether we need district dedicated M&E people. So question on sustainability district M&E people, and how GUI requirements are met through this system.
Actually, divisional M&E hub will stay because GUI has already approved it. And for district level M&E hub, M&E people, the proposal can be sent to Government of India, because as you know, we are totally dependent on Government of India's funding. So if we get approval from there, so there won't be any issue in that. But we are totally relying on Government of India's approval for that. And what was their other question?
Your thoughts on taking over the system, to ensure sustainability. I know, I mean, it is within the system, but when partner support is actually weaned off, whether the system is ready to actually pick it up and sustain the same quality.
Actually, that is a policy level decision. It will be taken at appropriate time and by the appropriate authority. So I think whenever that question will come, we will see what kind of policy decision is taken.
Okay, thank you. Huzaifa, to you, one question quickly, very interesting one, and that shows, people are sort of looking at data deeply. Very few newborn care linked decision actually depicted in the decision tracker bit. So do you have any insights on that from what you've learned? This question was from Marianne. And apologies, everyone, I'm actually mixing these questions and trying to club them into categories, and that's the reason I'm not picking up very specific individual questions. Over to you, Zefa. I can't hear you. Zefa, can't hear you. Ravi, can you pick up that question? I think we might have.
Yeah. Am I audible?
Yeah. Hello.
Yes.
Am I?
Yeah. Okay. Huzaifa is also there. Yeah, Huzaifa, go ahead. So, yeah.
Okay. Yeah. Okay. So actually, to begin with, so we have prioritized the 14 indicators which is available in the dashboard, and we developed the program pathway for each of the indicators. So, for example, the indicators was there like the 4 ANC checkups, the institutional delivery, and the indicators like the full immunization. And we developed the program pathway that what are the availability factors are actually affecting these outcomes. So what we have seen is actually it's just because the system is established, and to begin with they are more focused on the antenatal and the delivery care, and based on which they are easily able to understand also, and it mostly includes the community level factor. So this is what we have seen also, that the most of the decisions were on the antenatal was the first area, the second area was the delivery care, and the family planning and the newborn care was actually came later into the sequence. And it's quite even difficult for the district team, the capacity of the district HMIS operator and the district program manager to analyze those kind of factors were actually difficult that period of time, because it's just the findings of the 1 year of the time. So now we are actually focusing on some of the domain wise decisions like the asphyxia, we are picking it up, we are picking the low birth weight as indicator. So because initially we make a list priority of the state at that point of the time, but now we have seen, understand there is a few of the new to reduce the newborn care mortality, there are few of the domain like asphyxia, low birth weight, and now we are planning to pick those domain wise analysis, and so that we can have the decision on it.
Thanks. I'll just take a couple more questions, and then we'll have to summarize and wrap up from our side. And apologies, and at the same time requesting organizers to post the email ID on which people can share their questions, and we'll facilitate answers by presenters and discussant on those specific questions. The two questions I wanted to pick up, very interesting separate category of question is what's the backbone required for implementing such a huge project in terms of infrastructure, quality of human resources, etc. And sort of that kind of links to the some bit sustainability bit. So that, Ravi, if you can take that question quickly. And uh, before that, what are the mechanisms to ensure that people do not miss out on reporting information in UPHMIS? Now that it's paperless, there is less duplication, etc. But are there mechanisms? So either Huzaifa, could you pick up that question, and then I'll go to Mr. Jan with one final question, and then we'll wrap up. Ravi first, and then Huzaifa.
Yeah, thanks, Vikas. And I think that is a very pertinent question, because when we are talking about any system establishment, like I believe, and is that you have to think at that point in time about the transition, because it is not that once you have developed and then you think about it. So for this system, I think there are two key backbones. One is that of course the IT is something which is there, and then the humongous data. But I think the acceptance, I would say, from the users about data use, I think that is the backbone. And many a times we have seen that the systems got failed because they were implemented and they were not user friendly. So what we found now is that for instance, the government or the state is every month using the dashboard information in such a way that the meetings are happening, and the lot more decisions are being taken based on that. So I would say that you have to see the user perspective, that what they want, and if it is feasible to what people want, the acceptability will be more. And I think that is a part and parcel of the backbone, because you have to have that initial assessment to understand the requirement, and thereby looking into what kind of solution, not only in terms of technological terms, but also in terms of the technical as well as analytical terms are required to kind of sustain that system and make it more user friendly. Thank you.
So yeah, thank you. So to the second question, that how state is actually ensuring the reporting from the different 28,000 facilities are there. So we can classify into the three things. So one thing is that what we can see as the capacity of the reporting person. Second thing, what we see as the accountability, and third thing, what we see as the incentives. So there is a different provisions have been made in the state. So say for suppose about the capacity. So what we see in the UPHMI subcenter level application, everyone was at the apprehension that whether ANM would be able to report on tablet or not. Everyone has the apprehension ANM would not be able to use it. But we just see it, ANM just have the right application, and whether if it will provide the some incentive, because everybody would like to report whatever work they are doing it. So that's what we see, that if the person have the clear understanding, that would definitely do it. So this is about the capacity. About the accountability thing, the state has established, we already discussed, the one is the validation committee. So one of the agenda point of the validation committee is the availability of the data. So there is a different 4-5 agenda points about the availability, consistency, completeness, correctness. So availability is the first component, so which validation committee is making them accountable whether the data is not available. Second thing is on every 15 the data is getting logged. So person will not get the opportunity if the data will get logged after the 15th of the month. And then there is an incentive too, because in the ranking there are indicators that if they will not report it, the district rank and all those things will become affected. So these are few of the measures which the state has established for reporting of these important data.
Thank you, Mr. Jain. Final question back to you around how well this whole sort of data use process and quality assurance system embedded now within your sort of program processes and structure. This is still continuation of that whole sustainability bit, but we are not talking about partner support, weaning off, etc. But from your own systems perspective, how well it is now embedded within the system and your sort of daily routine for review and governance.
See, if you look at the ranking system, there is a dashboard, and then we have introduced the ranking system. So that ranking system is well accepted by the districts. So if you see districts now, they have that feeling of competitiveness. Among the blocks, there is a feeling that the district's performance should not be below the previous month performance, and just because of any particular block, some indicator, there should not be a decrease or decline in the performance of the district. So, this system is now well accepted as far as my understanding is concerned. So I can see now people are well aware when they are supposed to report data, as Huzafa has just explained. By when they are supposed to report data, because it will deduct or their ranking will be affected. So now it is part and parcel of their reporting system. So now people are well aware of the consequences. So that way you can say now the data is used in their decision support system on regular basis, and DHS is made aware of what kind of reporting they have done during the month.
Thank you so much. Thank you so much, sir. And with that, I'll sort of come to bring this webinar to a close with a quick summary of what we discussed in a bit. But first, I'll thank everyone who have put in their questions, and apologies we could not pick up all, but we'll pick up through emails some of the responses. In summary, just wanted to bring to attention through various presentations and sort of reflections by our panelists, the whole process of following the right design principles to ensure that at least for the system there isn't duplication. Effort for people to report into the system is minimal. Taking an iterative process of actually designing the system, I've seen the system actually reduce data fields to ensure that only what is used is actually reported in the system, and then bringing a big focus on quality and ensuring that there are embedded systems for quality assurance and government owned systems to actually nudge for quality, actually seems to have created a sort of data system which is adequately used in the system and has sort of reasonably good quality, and actually in some sense also meets the requirement of reporting from various levels. For future, I think from future perspective, some of the sort of points around building internal capacity actually in form of digital backbone and systems to actually own now the whole sort of architecture within NHM or health department scheme of things, and then at the same time bringing integration of other data systems into this, and ensuring that the data is also actually populated through beneficiary level information, etc., are some of the future sort of directions which possibly the state intends to go. But all in all, I think the quality and utilization of system is only driven by how well the overall leadership and ownership of the whole process is by the government. And our discussants comments actually very emphatically sort of prove that there's enough ownership within the system. So with these sort of reflections, I'll close this webinar. I'll thank Ravi and Huzaifa for taking us through the presentation, an elaborate presentation, and answering on all questions patiently. And also thank Mr. BK Jain for being here and sharing your experiences and insights into this process with our audience. So thanks everyone. Closing this webinar now.
Thank you, Vikash, from our side to you, and thank you, Trisha, for managing it from the back side. Thank you.
Thank you, everyone.
Thank you. Bye-bye.
Thank you, everyone.